Again for the third time, but this was not actually my talk, somebody else, but here I'm again in front of you. Now it's very difficult to remain awake after during the postprandial lectures. We know it's a natural thing. We have passed through these stages, and there is nothing you can do about it except to have good time in the form of a sleep. Now the aims and objective, as Dr. Nasir has instructed us to give aims and objective precisely before the lecture, so there you can read the aims and objectives. By the end of the presentation, you should be able to recognize the common eye deviation in childhood and adult, common lid condition and neck cell disorders, and to treat them at your level, and should be able to know when to refer to us, and to learn common causes of exophthalmos, proptosed, forward staring looking eyes, eyeball, and other orbital disorder, and to refer them in time. Now the presentation includes classification and diagnosis of squint to the extent you should know, not more than that, and common lid conditions, their gross management, and then thyroid associated disease and exophthalmos. Now something about the eyeball movement. Eyeball movement, it's basically the eyeball can move in any direction, up, down, right, left. It's a combination of 6 different muscles which are moving the eyeball in different direction. There are 4 recti straight muscles, the upper, lower, median and lateral, and there are 2 obliques which run obliquely, and the action of the oblique is to move the eye in difficult direction, number 1, and rotate the eye when there is a rotation required, like during reading, etc. Abnormality with this movement is invariably leads to a deviation of eye, misalignment of eye, which is called squint, or in ophthalmic term as strabismus. Now you can see that there are 3 muscles. The superior and inferior oblique, they are inserted in the posterior quadrant. Superior oblique in the superior area and inferior oblique in the inferior area. But the difference between these 2 muscles is that the inferior oblique arises from the medial wall of the orbit and goes directly to be inserted into the posterolateral quadrant of the lower part of the eye. However, the superior oblique it actually turns with the help of a trochlea to be inserted posteriorly again. You can see the 6th number, there is a trochlea, there is something which actually turns the muscles, and the muscle is inserted there. Now it's very easy to quickly examine the ocular movement by making the eye to move in a fashion of H. Now if this is the primary position of the eyes, we check the eyes with both the eyes open, and if you just draw H, like you can see here, all the 6 muscles are checked. Now I would not like to go into the details, but it's very simple to just ask the patient to look at the finger, and you just have to draw an H. All the 6 muscles are checked by this simple maneuver, and it will take less than a minute to check both the eyes. You can check individual eye, you can check both the eyes at the same time. When we check the individual eye, it is called the individual eye movement, and when we check both the eyes at the same time, it is called gaze of the eyes, gaze. Now squint or strabismus is misaligned eyes. Generally they are divided into 2 different types. One is, easier terminology is paralytic and non-paralytic. Paralytic when the muscles or the nerves are not functioning properly. There could be a physical reason for the muscles to be non-functional or under-functional, or there could be problem with the nerves not properly supplying the muscles. So either of the two can lead to a paralytic squint when the eyeball does not go in the direction of that muscle or nerve. Now if you recall your anatomy knowledge, there are two muscles in the eye which have solo nerve supply: the lateral rectus, which is supplied by the sixth nerve, and the superior oblique, which is supplied by the fourth nerve, trochlear. All the other muscles are supplied by the third nerve with the help of two of its branches. Now the paralytic squint is also known as incomitant or non-concomitant squint. Now there is a squint in which there is no element of paralysis present. All the muscles and the nerves are functioning properly individually, but with both the eyes movement, one eye is either under or overdoing. Now that is a condition which is called a non-paralytic squint or concomitant squint. This is the common squint that we see in our clinic and in children especially. Now why two eyes are there? We know that there are lower animal like goat or rabbit, they have eyes on the side. Now when the acute vision is not required, when depth focus is not required, when stereopsis is not required, the eyes can be placed on two sides. Now in lower animal like goats or rabbit and other animal, the eyes are placed on the lateral side to give a broader field of vision, but that's an individual field of vision, which means that the brain is reading one field at one time, and that is required to actually run away from the scene of predator, from the predator or from those larger animal to which they are actually afraid of. When they have to run away from the area of fear, they need a larger field. They don't need very good sharp vision, they need a good field of vision. That's what they have. They have a larger field of vision by the eyes placed on side. But for those who are actually doing the hunting, including man, the eyes are placed in the front, which means that the field of vision is seen by both the eyes. But what is the requirement of both the eyes to be placed in front? The requirement is that you need not to just read or recognize color or object. You need to have depth perception. Now depth perception is stereopsis, as we call the depth perception, when one eye see different field, different view, and the other eye see another view, and in the brain both the images are fused to give the depth of anything. Now the commonest example would be, if you with both the eyes open, if you like to guess the distance between you and myself, you can exactly to the extent of 95% or so, you can guess that this is about 5 meters. But if you close one of your eye, the depth is gone, the stereopsis is gone, binocular function is gone. It is very difficult to estimate the depth. So one eye vision is two-dimensional vision, and two eye vision, binocular vision, is a three-dimensional vision that we have. Now you can see that one eye is seeing these what you call the billiard bottles. You can one eye is seeing on the lateral side, the other eye is seeing on the other lateral side, and that's the reason you can appreciate there are 4 or 5 bottles standing there. Now this is a depth of vision, or stereopsis as we call it. Now if we divide I'll just touch the concomitant or non-paralytic squint, since very common, and how do we classify these? If the eyes are absolutely straight, we call the eyes as orthophoric. Orthophoric, it means that they're absolutely straight eye. It's very simple to check the straightness of eye. You can do it by throwing light into the eye, and we know that the eye is the light is reflected back through the cornea. If the reflection is from the center of the cornea, the eyes are straight. Now if the eye is converging, the reflection goes temporally. This is called esotropia or convergent squint. Now there is another squint which is prevalent, and that is called phoria. Any squint which is not present during the normal situation and is revealed only in case of some cover test is done, that is phoria, hidden squint. But any squint which is obvious without the cover test and it is seen in the clinical examination is a tropia. Eso is when the eye is deviated towards the nose. Exo is when the eye is deviated outside the nose. So divergent squint is exotropia, convergent squint is esotropia. At times the eye could be displaced up and down. In case of up deviation, it is hypertropia, and in case of down displacement, it is hypotropia. You can see it's the divergent squint, it's the convergent squint. Now the diagnosis here would be right convergent squint, the diagnosis here would be right divergent squint. Over here would be, you can see the white of the eye between the limbus and the lower lid margin. It means that the eye is deviated upward, is right hypertropia, and over here is the right hypotropia. You can see a couple of examples here. This is the esotropia when the eye is converging towards the nasal bridge. This is the left esotropia, this is the left esotropia, this is right exotropia or right divergent squint. Now I would like to add here, in children, divergent squint, this is something which is not very simple pathology. Invariably it is associated with some serious ailment like retinoblastoma, like congenital cataract, like some degenerative disease of the retina. So divergence is, number one, not very common. If at all it is present, it needs a very, very thorough examination, including the retinal examination. Convergent squint is very common. 80 to 85% of the squint that we see in the first 3 or 4 years of life, that is convergent squint. And out of this 80% of convergent squint, more than 75% is accommodative squint, which means that the child is accommodating to the extent that he or she is converging the eye towards the. So the answer is proper refraction, proper glasses prescription, and the eye would become straight without any surgical intervention. Now I belong to that school of thought where surgical option for squint management is the last management. I normally don't touch. I try my best to control or correct the deviation without surgical intervention. So is my approach of management towards glaucoma, chronic simple glaucoma. Now another convergent squint, but there is something additional present here, and that is it's a flat bridge of the nose. Now it's very common in obese, healthy child, infant, that they normally have a flat bridge, and it normally raised in next couple of years time, and because of the flattening, the white of the eye, you can see the white here, but you don't see any white of the eye nasally. It gives an apparent look of squint. Actually the squint is not there. Here the squint is here, is definitely present, but at times apparent squint is present, and that is because of the flat bridge of the nose. Simple test is just throwing the light into the eye, and the reflection is from the center of the cornea in both the eyes. It is not a squint, it is apparent squint. It looks squint, also known as pseudo squint, and the answer is no management, no treatment, just reassuring the parents, and in 3-4 years time it will be all right. Well, if you like to have an opinion, you can always send us such patient. Now the treatment is, as I said, the accommodative squint is treated with the corrective hypermetropic plus lenses. and those requiring surgery do very well. But of course, for different squint, the management age is absolutely different. For certain squint, 18 months we operate. There are other squint we operate at the age of 3 years, and then 5 years, 8 and 18, or different. So the management is a different subject I will not like to touch, but you can see that after the surgical correction, the eyes becomes orthophoric. Now that's all about the squint. Now we come to the orbit. Now the orbit, the skull consists of 85 openings with 22 bones divided in cranial and facial bones. Now as far as the eye is concerned, we are concerned with the orbit, the orbital wall, and the openings that the orbit has. Now there are 4 openings in the orbit: the superior orbital fissure, the optic canal, inferior orbital fissure, and what is the, may I ask, what is the 4th opening in the orbit? That's the answer. That's the opening of the orbit. That's the 4th opening. So the bones which you can read, the bones which are involved in the formation of orbit: the frontal, sphenoid, zygomatic, maxilla, palatine, lacrimal, and ethmoid. Now the next orbit are the orbits are intimately related to the sinuses. All the 4 sinuses are actually around the orbit, and they are related to orbital disease. They may be the initiator of orbital disease, like orbital then sinusitis leading to orbital cellulitis. You can see that these are the frontal, these are the sphenoid, this is the ethmoid, and here lies the maxillary. Out of all the 4 sinuses, ethmoid has got a very, very thin wall, which means that inflammatory process can very easily enter into the orbit and can invade the orbital tissue. Now if you go back to the knowledge on red eye and before that, we divide inflammation of the orbit generally into 2 types: pre-septal cellulitis, where the septum is the watershed area. Behind the orbital septum there is no inflammation. The inflammation is right in front of it. It's not a serious problem, settles by itself, but of course can go into the orbit and leads to orbital cellulitis. This is pre-septal cellulitis. You can see that the eyeball looks healthy. Inside the eyeball, the signs are present well outside, not inside. Now this is not pre-septal cellulitis. This is the orbital cellulitis. You can see the orbital sign in the form of conjunctival chemosis and congestion. Inside you can see that the eyeball itself is pushed forward, and you can see that the signs of proptosis are present as compared to the last picture. Where the signs are limited to the skin only. The signs are not limited to the skin. Actually minimal signs are present in the skin, and the major signs are present behind. So it is a potentially vision and life threatening condition. Inflammation of the orbital content posterior to the orbital septum often originate from the paranasal sinuses. So one must think of sinus pathology in case of orbital cellulitis. In examination, there may be problem with the ocular motility. Pain is definitely there. Proptosis is forward pushing of the eyeball. Decreased vision, afferent pupillary defect if the pressure is very high or the inflammation has reached the optic nerve, then there could be afferent pupillary defect. It's a very, very simple test. It will take not more than 5 seconds to check the pupillary responses on 2 sides. And there could be optic disc edema, which shows that the optic nerve is involved. Now that's very advanced orbital cellulitis. You can see now the picture is not very clear, but you can see that the other eye is also closed. The patient is not very ill looking, and it's closed eyes, and you can see a lot of swelling This is the advanced orbital cellulitis stage. Now, orbital cellulitis at times, if arising from ethmoid sinus, bilaterality is a rule, but one orbit can transmit the infection to the other orbit as well, and most of the time we see bilateral involvement. But that's a very, very dangerous sign, because bilateral involvement is a hallmark of cavernous sinus thrombosis. Now, what do we do during the clinical assessment of such patient? We need to check the eye temperature, which is raised in inflammatory process. Visual acuity, if the eye can be open, visual acuity can be checked. Fundus examination is very important, and proptosis measurement. Now, measurement of the proptosis actually gives you an idea of deteriorating condition or improvement in the general condition. So that could be very helpful. And movement of the eyeball, the extraocular muscle should also be assessed, and neurological sign. CT scan is very important, and it gives a lot of information in case of orbital cellulitis. We can see that there is some lesion on the medial wall of the orbit arising from one of the sinuses. It has pushed the eyeball laterally and outward. Now, these are the list of investigation. Now, out of all the investigation that we advise, I think it's worthwhile advising a CT scan. This CT scan is different from CT scan of the skull or head, because they have very special slices being done in called the special slices orbital CT scan or MRI. So they give a very magnified view of the local pathology. Now you can, there's a different view. This is the pathology in the sinus, and it has actually invaded the eyeball from the front, and you can see that the eye is proptosis, and you don't see eye, very well marked proptosis on the right hand side. You can see that there is no remains of the you don't see any marking of the eyeball on the left side, on the left hand side, and this is because the eyeball has proptosed to the extent that the eyeball actually is lying outside. Now, what do we do in orbital cellulitis? Immediate hospitalization and IV antibiotic covering all the gram-positive, negative, and then aerobes, anaerobes, they are actually, we start with multiple therapy. The idea is to save the patient eyesight and to save the life of the patient, because if once the cavernous sinus is involved, the mortality is very, very high. Analgesic and surgical drainage if subperiosteal abscesses are present, confirm on CT, and it's very, very painful. The complication includes of the orbital cellulitis extraocular palsy, which could be permanent. Corneal, now because of the proptosis, the eye, the cornea is lying outside, the conjunctiva is lying outside, and can be damaged because of the exposure. Optic nerve damage due to proptosis, and meningitis can occur, and a very serious complication of cavernous sinus thrombosis. Now, has nothing to do with the orbit or the lid, but just here comes another important topic, and that is thyroid eye disease, TED as it is known as. Quite common. Not necessarily thyroid eye disease is associated with high thyroid hormone level. Now that's very important, because it is diagnosis of thyroid eye disease does not require a high level of thyroid to be present in the blood. Thyrotoxicosis is an autoimmune disorder, and there are different names. You can read the names. It is known as during the clinical practice. What are the signs and symptoms? It presents with painful ocular. Then that's the early presentation. They present with painful ocular movement in all gaze, and this is because that the the inflammatory tissue that is being deposited in the muscles to start with. So that is the reason of painful ophthalmoplegia. Because of the proptosis, the eyes are dry, itchy, difficulty in wearing contact lenses or glasses. At times the eye actually touch the back of the glass of the spectacle. There could be inflammation and swelling of the conjunctiva and orbital tissue. Swelling of the orbital tissue causes eye to be pushed forward, which is called exophthalmos. Now the difference between exophthalmos and proptosis is forward protrusion of the eyeball in one eye, and exophthalmos is a bilateral phenomenon, which is a hallmark of thyroid eye disease. It gives a very staring look, it's very easy to diagnose. The moment patient enters into the clinic, it's very easy. You see a very bulging prominent eyes in the middle age group, 3rd and 4th or 5th decade of life, and a very slow upper lid movement, what is known as lid lag. They move the eye very slowly because of the pain and restrictive myopathy. The eyes are proptose, bulging forward of the eye is visible, and very infrequent blinking and slow movement of the upper lid. So these are the clinical signs that you don't have to ask, and you can diagnose immediately in this condition. Now the previous picture was at the early stage. Now you can see that the advanced stage, a lot of swelling around the eye. All the conjunctiva actually is lying outside. That is because of the conjunctival chemosis. Now once this conjunctiva is lying outside, it leads to keratinization of the conjunctiva. It becomes hard, and so is the cornea. There are corneal ulcers, and then they heal with scar. The eyes are very, very dry, and you can see that the vessels are dilated in the conjunctiva. The effects leads to conjunctival congestion and chemosis, double vision because of the muscles restriction. Muscles are not functioning properly. Not only the muscles are swollen, the orbital fat and contents are also increased, that they actually cause difficulty in the movement of the eyeball and impair vision because of the pressure from behind. Thyroid eye disease go in remission and relapse, but of course they need to be very carefully observed and treated. The diagnosis is atypical, as I have already mentioned. Orbital special slices for CT and MRI. Thyroid serological test would be helpful, but not necessarily T3, T4 or TSH may be high. What we do in such cases, we in making a diagnosis, at times it's difficult to make a diagnosis. The obvious signs are not there, but then we ask for special slices of the orbital with the CT. That may be helpful, and it might give some swelling of the muscle. The most commonly involved muscle is the medial rectus, followed by inferior and then around the clock. And the association of thyroid autoantibodies, thyroid stimulating antibodies. There are a couple of other antibodies also available, but of course these tests, as far as I know, is not done in Lahore. So we have to send these tests elsewhere for confirmation. Now this is a CT scan of thyroid eye disease. Not only that you can see that the eyeballs are proptosed, the muscles are very grossly thickened. The medial rectus is thick, lateral is less. You can see that the medial is thick, but it's so visible that single sign would make a diagnosis. You can see all the 4 muscles. This is the optic nerve. You can see that normally these muscles should not be swollen to the extent seen here, but it's a very, very swollen. These muscles are about 4 to 5 times the normal thickness of the muscle that you see here. So they are very grossly thickened. You can see that the muscle is also thickened here and possibly here as well. The optic nerve is also decompensated, and there is some swelling of the optic nerve as well. Now what do we do for thyroid eye disease? Control of symptoms and control of the disease. Control of symptom is exposure keratopathy. The cornea has to be saved, the conjunctiva has to be saved, the lid has to be patched during night especially. Some artificial tears, ointment, gels, they could be helpful. In advanced cases, plastic repair, narrowing of the palpebral fissure, plastic surgery is also helpful. And for diplopia, we can give some prisms, we can occlude one of the eye, and we can do something with the muscles recession or resection in order to reduce the double vision problem. Now, one of the surgery that is done, of course, it's a specialized job. Not all ophthalmic surgeons are doing it, and that is the orbital decompression. Now, since the eyeball is there in the socket in the orbit, any increase in the content of the orbit can be decompressed elsewhere, and that is, in the maxillary sinus is the commonest area, where if the roof of the maxillary sinus is fractured, the orbital content can go there, and there could be some decompression and reduction in the proptosis. Now, this is the example of orbital decompensation. You can see the staring, glaring, caucus look of the eyeball here, and after decompression and lid plasty, the condition is looks little better. On the left hand side, besides the proptosis, the muscles restriction was also there, and some strabismus surgery was also done with the decompression, and you can see that the look has improved. The orbital tumors, I don't know how much time left. The orbital tumors can also present silently or with some very serious symptoms. There could be development anomaly in the form of dermite cyst, very common actually in the GP clinic. There could be some vascular tumors, lymphoma, lacrimal gland tumors, etc. Hemangioma, another common problem. Now, there could be two types, the capillary as well as cavernous. Capillary occurs in infants and young age, and it settles normally in 6 or 7 years time. However, the cavernous hemangioma occurs late in life and can cause proptosis and double vision. Now, that's the capillary hemangioma, and this hemangioma is present not only in the skin but in the orbit as well. So it has pushed the eye slightly towards the lateral side, temporal side, but these tumors, capillary hemangioma, in 6 to 7 years time they settle by itself, and nothing is required actually, unless there is some indication. We can give injection within the steroid injection within the lesion, or give some hot water injection as well. They are very helpful, of course, but not normally done. Now, next. Now, this is the cavernous hemangioma, and it has caused proptosis. The eyeball is pushed forward and downward. The lesion is behind the eyeball. The problem is that it's a very gradually, slowly progressive lesion, which normally is present behind the eyeball, and it's very well encapsulated. So surgical treatment is very successful. Dermite cyst, I'll just give you a picture of the dermite cyst. You know what dermite cyst is. There's the small dermite cyst present here, and removed surgically very successfully, leading to no problem with the eyeball and the development of the that's a surgical excision, and it should be done not less than 1 year of age. Now, rhabdomyosarcoma, the incidence is very low, but it's a very aggressive tumor of childhood. In majority of cases, the presentation is acute, and by the time it is presented to the doctor, it has already spread to the body, and the overall survival rate is very low. Now, I'll just touch a couple of lids condition to give you an anatomy of the lid. This is the posterior lamella, this is the anterior lamella. Gray line is the junction between the two. You can see the lashes here, cilium. You can see the gland of mole. You can see the sweat glands and the Meibomian gland, which is located in the posterior lamella. Now, one of the pathology that we see in the clinical practice is stye. Stye is a problem here. It's the infection of the root of the lash. Squamous blepharitis, another common presentation in the outdoor, is a problem of the anterior lamella right here. Clesion, the third most common presentation in the outdoor, is problem with the meibomian gland. Now blepharitis is a common inflammatory condition that affects the eyelid. Now if you just look at the picture, this is a normal eye, it's very clean, normally convex lashes, no scales deposit here. But in blepharitis, you can say that the scales are deposited at the root of the lash. The sign and symptom include sandy, itchy eyes, red, swollen, depends on the chronicity of the disease, and at times dandruff of the scalp is an associated feature. In slightly chronic condition, you see that the root of the lashes are actually embraced with these scales, and they don't go very easily. They require a lot of effort to clean it. So I'll come to the treatment later on. In blepharitis, we divide into two: dry, simple, or ulcerative. Now this is the ulcerative. The previous one was simple. In advanced cases, there are ulceration and they heal with scarring of the lid margin and tylosis. Tylosis is a thickened margin of the lid. Another picture, they ulcerate, bleed, and then they heal again. So it's a remission and relapse that goes on and on. Treatment is very simple: lid hygiene, control of dandruff. I don't know it causes a beneficial effect on the blepharitis or not. I have no idea, but it is conventionally associated with the blepharitis. Antibiotic to control the infection. Steroid. Lid hygiene means frequent cleansing and putting some Vaseline or oily ointment at the root of the lashes. That controls the dryness. They may cause repeated blepharitis, can cause repeated styes and other lid problem as well. And they can actually rub the cornea, can cause keratitis and conjunctivitis. Stye is another common, it's the bacterial infection of the root of the hair lash. That's the early stye. These stye do happen, but they are self-limiting. They heal by itself. Nothing is required. The body defense system control it. But in advanced stages, they can actually cause painful swelling of the lid. In the upper lid, they can, with each blink, cause painful movement of the lids. And clesion is the problem with the meibomian gland, the oil fat secreting gland. Now why fat is required? Fat is required. If you look at the normal wetting of the eye, the water or a tear contains three layers actually. One is the mucus, second is the watery, which is 90% of the tear, and the topmost layer is the fat secreted from the meibomian gland. Now the role of fat is it keeps the water there, it keeps the eye wet, it does not allow the water to evaporate, so it is required. Inflammation of these glands is seen as clesion. Normally it's a sedentary inflammation, it does not cause acute inflammatory sign. Gradually it increases in size and can cause actually pressure over the eyeball, or little pressure over the eyeball can change the refractive state of the eye, and that's the reason it needs to be removed, especially when present in the upper lid area. The lower lid can be delayed. Now that's the infected clesion which has actually come out, and it's so thank you very much for being attentive. Still something more to come. Stye is the inflammatory process of the root of the lash, eyelash. Well, it's very simple. We don't see any mouth or opening of the clesion at the lid margin. In case of stye, the pathology is at the lid margin. You can see the mouth of that inflammatory process at the lid margin. If you go back to the anatomy, it's very self-explanatory. Now, a couple of more conditions if you are interested. Entropion, when the the lashes are turning inside, and trichiasis, when the lashes are misdirected, and you can see the example here. Even single lash can rub the cornea to the extent to disturb you throughout the day. I think we finish here. Achha. Entropion is inward turning of the lids. You can see that this is the lower lid turning inside, and it's a problematic condition. Now the difference between piche wala jai. This is old age problem, involutional, and this is young subject. So see the force of actually in-turning. Ectropion is outward turning of the lash, of the lids. Could be involutional, cicatricial, paralytic. Now that's the example of entropion, and that's the example of ectropion. Now this is very common in the outdoor. The lower lid actually is everting outside, and because of the laxity of the muscles are not functioning properly. And the problem with this ectropion is that it causes watering. Whatever water which comes from the lacrimal gland, it does not ascend from here into the lacrimal punctum and falls out. Chronic exposure can lead to keratinization, hardening of the conjunctiva. Ptosis is drooping of the upper eyelid, could be congenital or acquired. That's the congenital ptosis. Now the easy way to diagnose congenital ptosis is presence of this fold is not there, which means that the muscle has never functioned. And if there is no fold, it means that it's a congenital ptosis. Or when there is a fold with ptosis, it means it's an acquired or adult ptosis. Fold is there, which means that initially the muscle was functioning, but over a period of time it has become non-functional. The treatment, of course, is a surgical treatment. Lid tumor, I'll just give you overview. Melanocytic tumor, vascular granuloma, and viral wart. It's a vascular hemangioma of the lower lid. It is seen actually shining through the skin, so it's easy to diagnose. Next. Hemangioma of the upper lid, but it's unlike the previous one, it is a flat lesion. But what important malignant tumor that can arise from the skin? The commonest is a basal cell carcinoma, and then the squamous cell sebaceous and melanoma. That's the small nodular basal cell carcinoma. If a lesion is there for 6 months or a year and very slowly progressing after the age of 60 years, I think this is the diagnosis. In case of ulcerative, it is ulcerating and it is a progressive. Nodular does not grow very quickly. The ulcerative grow quickly and erode the surrounding area. Another basal cell tumor here. This is a sebaceous cell carcinoma. And that's the melanocytic or a pigmented lesion. So any pigmented lesion which occurs in the older age group and which was not there before, a very simple test would be you ask the patient to bring some old photograph, and you can compare if the lesion was not present before, possibly it is a tumor and possibly it is a melanocyte tumor, which is a difficult situation to control. Thank you very much. If you have any questions.